Thank you very much. First of all, I would like to thank the organizers for inviting me to this meeting, and I am very pleased to be with you. The objective of my presentation is to share with you my experience of developing biological markers of blood activation, direct markers of blood activation, or indirect markers which can contribute to enhancing blood activation. So first I will remind the basic physiology of hemostasis, because it is important to understand how these blood activation markers are useful and how the technology can help us in developing new approach and new markers for exploring this blood activation during the silent phase of disease evolution. So this slide shows the circulatory system, and it is important to remind that it is a very important surface, a very large surface, which, if all the endocellular surface of the body is spread, it could cover the Place de la Concorde in Paris. So it represents how large it can be, and this helps to understand that everything which occurs in the body, physiologically or pathologically, can have repercussions on blood. So hemostasis is then a major host defense mechanism, as is the immune system too, and its functions are, as you know, to maintain blood function integrity by preventing hemorrhage and by fighting thrombosis. This reminds the balance between procoagulant activities and antithrombotic functions. Antithrombotic functions involving endothelium, inhibitors, protein C, protein S, and thrombomodulin system, and fibrinolysis. And on the other side, procoagulant being induced by endothelial lesion, inflammation or infection, arteriosclerosis, many disease states, stress, and this can induce generation of procoagulant factors. And with this balance is maintained in equilibrium, then the blood flow is works correctly and nothing occurs. And when there is a disequilibrium, then a disease can develop and thrombosis can occur. So hemostasis is then a pre-programmed biological system which starts automatically when there is a risk, a bleeding risk or an hemostasis risk. And this is a very efficient control for preventing hemorrhage and for fighting thrombosis, which makes that most of the stimuli remain clinically silent. So this schema reminds the coagulation pathways, intrinsic and extrinsic, with the crossroads at factor 10A, thrombin generation, and fibrinogen. And this is a triggered mechanism. So it is initiated at the local site where blood coagulation is activated. Because there is a cell lesion, or because there is endothelial lesion or atherosclerosis plaque or plaque rupture, and this can initiate blood coagulation. And what is important to remind is that the early phase of blood activation are very low, and they contribute to generate only trace amounts of thrombin, which can be controlled, and then it remains only in this initiating stage. But if enough thrombin becomes available in blood circulation, then it can amplify the process, and it can induce generation of large amounts of thrombin, and fibrin can be clot, and then the clot can be formed. So the very huge amounts of thrombin are then formed, and the clot is initiated. This slide shows that before producing a thrombus clot, there are many defense mechanisms in body that you are familiar with. They include, at the early stage, TFPI, protein Z inhibitor, and glycosaminoglycans, mainly present on the endothelial surface. Then we have the group of inhibitors and protein C, protein S system, and finally fibrinolysis. What occurs when there is blood activation? When blood activation occurs, at the very early stage, there is endothelial activation and platelet activation. which can induce release of some cell activation products in blood circulation. And for platelets, we know BTG, PF4, microparticles. For endothelial cell also, we can have soluble forms of thrombomodulin, increased concentrations of von Willebrand factor, or endothelial cell microparticles. And this can be blocked by the early defense. If blood activation progresses, then they can overwhelm this defense and other systems become activated and new markers are generated. This can be factor 7A, factor 12A, some peptide activation release from proenzymes when they are activated to enzymes. And here again we have a new defense system involving antithrombin 3 for many serine esterase, heparin cofactor 2 for thrombin, and the protein C protein S system, which is mainly efficient in microcirculation by preventing dissemination of thrombin activities. And if this is not sufficient, then fibrin monomers and soluble complexes can be generated in blood circulation, and we have a new defense mechanism with fibrinolysis which can also stop progression of this. And only when all these defense mechanisms are overwhelmed, thrombus formation can occur. Now, before the final stage of thrombus formation is reached, many blood activation markers can be generated at the different stage of blood activation, but they are generated in the clinically silent phase. Clinical symptoms mainly occur when thrombus is formed. So the characteristic of these blood activation markers is that they are present during the compensate progress until overwhelming of body defense against thrombosis. This is a clinically silent period, but the blood activation markers are present and they can be derived from plasma proteins or from blood cells. When disease occurs, it is sudden, it is frequently sudden. And then we need the support of therapy for enhancing blood defense and for restoring health in the patient. This slide represents platelet activation, resting platelet, and platelet during activation. And you can see here the pseudopods, and you can see that some microparticles can be released from platelets. And now we can measure these microparticles generated from platelets, but also from other blood cells. Here again you can see the progress of platelet activation, the resting platelet, the pseudopods. So you can make the connection with the very nice presentation of Professor Kenman on hemostasis activation. And from these pseudopods, some microparticles can be released, and they constitute very useful markers of the disease evolution and disease stage, and also for monitoring therapy efficacy.